So yes, after that we're going to go for the inspection of the anterior chest wall. Yes. So before we go forward, special shout out to one of my students who upgraded us from this to this. So thank you a lot. It means a lot. It's very supportive of you guys. So let's go on with it. So in the anterior aspect of the chest, we're going to try to inspect for any surgical scars or any therapeutic marks. So you have to know there's a difference between. For example, in terms of surgical scars, maybe that person has done a pneumectomy, removal maybe of a certain log of the lungs. Maybe it's due to a cancer that has spread to that area. That part was taken off. Maybe that person, therapeutic marks, has radiation tattoos. So those ones who are receiving radiotherapy, they have these radiation tattoos. You find them like this. Yes. And then maybe you also have someone who's having a chest tube drainage. So you can find this very common below the axillary region. So you find that there are marks of those such things. So after seeing the inspection of the chest wall, so we're going to check also for any chest wall deformity. Inspect for any chest wall deformity. Yes. This is very important. So you're going to check, is there any signs of kyphosis or scoliosis? Is there any signs of pectus excavatum? Which is like a funnel type of shape of chest. So you find that the chest is actually intruded inside. Funnel shapes. So most common in Marfan syndrome. And then is it pectus carinatum, which is most common also in people with which is like a pigeon shape. And then you have something more which is of a barrel shaped chest, which is most common for people with chronic study of COPD and asthmatic patients. So in this case, you're going to, while the patient is seated, you're going to observe at different angles the shape of the chest wall. So it will tell you a lot about if there's any kyphosis or scoliosis, if there's any pectus excavatum, if there's any pectus carinatum, and if the patient is having barrel shape. So all these ones will give you a clue on what the patient might be also suffering from. So after that, we're going to do palpation of the chest wall. So talk about the anterior chest wall. So all you're going to check for, you're going to check for any signs of organomegaly. So if there'll be any signs of organomegaly or any signs of swelling. But then you're also going to palpate for the apex beat. So the apex beat is located at the 5th intercostal space, mid-clavicular line. So that means to your side, it's going to be the 5th intercostal space in this clavicular line. So obviously your hands is going to be horizontally placed on that side. So the mid-clavicular line, that means the clavicle, you check the medial part of the clavicle, the mid part of the clavicle, and then you start counting the 5th intercostal spaces. So from the 2nd intercostal space, you're going to get something called the bony preeminence, which is the sternal angle. So this marks your 2nd intercostal space. So from then you start counting the intercostal spaces until you reach to the 5th intercostal space in the mid-clavicular line. So sometimes the apex beat may be displaced. So what are the conditions in which the apex beat can be displaced? So sometimes they can also be displaced in terms of a pleural effusion. Tension pneumothorax. sometimes cardiomegaly. So in these conditions, you're also going to know that, okay, fine, maybe this apex beat is also displaced up to here. Yes. So ladies and gentlemen, after that, we're going to go for percussion. So in percussion, what do you need to know? You need to know how we do it. You also need to know the areas of percussion. And you need to know what we're looking for. So these are the questions that you're supposed to answer. So how do we do it? So obviously your weaker hand is going to be, preferably if your right hand, then is your left hand, is going to go flat, horizontally on the chest wall of the patient, and then you're going to percuss in a hammer fashion with your middle finger. So this is how you do it. But then what you should know, the areas of percussion. So in areas of percussion, what areas do you percuss? So you're going to take the anatomy of the lungs. So in the lungs, the upper zones or the apex of the lungs is located just above the clavicle. So that means that's going to be your first percussion area. So that means you're going to go to the first clavicle of the left hand side and you're going to percuss the second clavicle of the right hand side, clearly with the same pattern. And after that, you're going to go to the next point of auscultation, which is going to be the second intercostal space. So on both directions. So you're going to count the second intercostal space. As I told you, the second intercostal space, you'll find something called the sternal angle. When you're going to meet this bony prominence, it's going to lead you to the second intercostal space. So that means you're going to percuss on this side, and you're also going to percuss on that side. And then you're going to go to the other percussion, which is going to be in the fourth intercostal space. So this second intercostal space, it represents the mid zones of the lungs. So you may be asked, where are we percussing? So we're percussing the upper zones, the mid zones, and the lower zones to look for any abnormalities, because the abnormality can be in any among those zones. And then you go to fourth intercostal space, which is the lower zones. So you're also going to do the same percussion on both sides. So I hope you have understood on that. So we're going to go through, there's something called percussion notes. So we're trying to take note of the percussion note. So the percussion note. So in the different pathologies whereby you're going to get different percussion notes. So for example, you can get a hyperresonance. A hyporesonance. So what are the conditions you can get hyperresonance? So you can get hyperresonance in cases of tension pneumothorax. So this is a very common cause of hyperresonance. And then you can get something called a dull resonance. So the thing about dullness, there's dullness and there's stony dullness. So these things that you're supposed to actually know how to differentiate them. And this is done through regular repetition and getting to know the sounds that each one makes. So there's dull resonance, which can be seen in, for example, in lung consolidations, such as maybe you have your COPD, and then maybe you have your lung fibrosis. You see. And then what else? You can have a place which is someone has done a procedure, pneumonectomy. And then you can also have it in different cytogenic fibrosis. So that is dull resonance. And then you can have something called stony dull. I hope you can actually see a bit. So stony downs, you're going to get it in times of in time of when you suspect, especially when they're fluid. So pleural effusion and pulmonary edema. So these are the things that you will actually get to see. So I hope we're together. So these things you're supposed to note them down, get to know, and get to grips with doing a lot of cases, so that we can actually be able to differentiate between hyperresonance, diresonance, and stony dullness. Of course, this stony dullness is just like you're percussing the wall. So it's like a wall type of a wall type of what of a sound that it actually makes.